It is a true pleasure to introduce a colleague and a friend, Dr. Hassan Chami. Dr. Chami is a graduate of the American University of Beirut and did his training at Boston University and is boarded in the fields of pulmonary medicine, critical care medicine, and sleep medicine. Dr. Chami is currently an assistant professor of clinical medicine at the American University of Beirut, and he will be discussing with us pulmonary rehabilitation, the evidence behind it in COPD patients. Dr. Chami.
Thank you. I'd like to start by thanking the organizing committee for inviting me to give this presentation on the rationale and evidence of pulmonary rehabilitation in COPD. This is the outline that I'm going to follow throughout this presentation. We'll start by reviewing the mechanism and management of dyspnea and exercise limitation in COPD. Then we'll talk about the structure, the goals, and benefit of pulmonary rehabilitation. Then we'll move to discuss patient selection, so who to include in such programs. And at the end, we'll touch on the initial components of pulmonary rehabilitation, including the initial assessment, the exercise component, and the educational component, which will be elaborated more upon in the coming lectures. So, patients with COPD suffer from symptoms of cough, breathlessness, and exercise limitation, which together with frequent exacerbation and hospitalization would lead to poor quality of life. Cardiopulmonary dysfunction is the most important cause of dyspnea and exercise limitation in these patients. However, there's growing appreciation of non-respiratory factors that may be contributing, such as deconditioning and skeletal muscle dysfunction. So patients with COPD would start by experiencing dyspnea because of cardiopulmonary limitation, and then they would try to avoid this unpleasant feeling by reducing their exercise, which leads to inactivity and deconditioning. So they will assume a sedentary lifestyle which feeds into their dyspnea, and they go into a vicious cycle of increasing deconditioning and dyspnea and further reduction in exercise endurance. In addition to this deconditioning, the patient with COPD also have skeletal muscle dysfunction. This has been proven in few studies, and it's characterized by reduced mass and strength. So both mass and strength are reduced. Of course, deconditioning would contribute to that. However, there's other factors. Importantly, systemic inflammation has been shown to be more prominent in patients with COPD and negatively affect muscle function and mass. Oxidative stress, hypoxia has a negative effect on muscle function and mass. Malnutrition, which may be prevalent in severe COPD. The use of corticosteroids appropriately during exacerbation or inappropriately for maintenance can also have a negative impact on skeletal muscle dysfunction. And a subset of patients, especially elderly, will have anabolic hormone deficiency. So what we know about management of COPD, primarily dyspnea and exercise limitation, we use steroids, bronchodilators, and oxygen. These are the traditional pharmacologic therapy that address cardiopulmonary limitation. However, pulmonary rehabilitation would address deconditioning and skeletal muscle dysfunction. So we'll move now to talk more about pulmonary rehabilitation. According to the ATS-ERS statement, the last one in 2006, we're expecting one to come out soon, maybe next month in the ATS meeting. Pulmonary rehab is defined as an evidence-based, multidisciplinary, and comprehensive intervention for patients with chronic respiratory disease who are symptomatic and have decreased daily life activities. This is a very broad definition, and the main component of a pulmonary rehab program are exercise training and education. However, psychological counseling may be also helpful, especially that anxiety and depression are prevalent in patients with COPD, up to 30%. And nutritional counseling is also helpful for patients who are overweight or nutritionally deplete. Smoking cessation is also a must for patients who continue smoking. So through this multidisciplinary approach, pulmonary rehabilitation does not only address this vicious spiral of increased inactivity and deconditioning, but also impact muscle wasting, weight loss, altered mood, and relative social isolation important factors that affect patient quality of life. The goals of pulmonary rehabilitation in patients with pulmonary disease in general and COPD are to reduce symptoms, optimize functional status, improve quality of life, very important, that's what the patient cares about, increase participation in everyday activity, and all that while reducing healthcare costs. Who in the room thinks that pulmonary rehabilitation can achieve all those? Can I show a hand? Do you believe that pulmonary rehabilitation can do all those? Well, the minority that raised their hand, you're right, there's excellent and mounting evidence, level A we're talking, so randomized controlled trial and meta-analysis that shows that pulmonary rehabilitation improves exercise capacity, reduces perceived intensity of breathlessness, they also improves health-related quality of life, and reduce anxiety and depression associated with COPD. In fact, when pulmonary rehabilitation is compared with the same number of psychotherapy session, head-to-head, pulmonary rehabilitation is superior at improving anxiety and depression in patients with COPD. Same number of sessions, psychotherapy, pulmonary rehabilitation, patients have less anxiety and depression at the end. And finally, very important, and what makes pulmonary rehabilitation cost-effective, it's been shown to reduce the number of hospitalization and days in the hospital in patients who have previously exacerbation. So we'll review a bit of this evidence in a bit of detail because it's very important. So this is the Cochrane database review, a meta-analysis of 16 randomized controlled trial that includes 669 patients. And it showed statistically and clinically significant improvement in functional exercise capacity as measured by the 6-minute walk test. Patients were, on average, able to walk 48 meters longer. What's thought to be clinically important is about 35 in most studies, and some quote 50. So both statistically and clinically important. There's also studies, similar meta-analysis that show and improve not only in the amount of work that they can do, the length and the distance, but they can also, the peak intensity is also improved by about 8 watts, which is also considered clinically relevant. Similar meta-analyses also show improvement in health-related quality of life. This is, same thing, meta-analysis of 6 studies that looked at the St. George questionnaire, and there's an improvement, statistical and clinically meaningful, in their perceived health-related quality of life. Similar studies also are in a Cochrane database in the same review that shows an improvement in quality of life as measured by the chronic respiratory disease questionnaire. And here also the improvement is statistically and clinically meaningful. The cut point is usually 0.5 for a meaningful improvement on this 7-point scale, and the improvement on average is 1. And also this is for the dyspnea dimension. There's 4 dimensions to this questionnaire. They're all improve in patients who undergo pulmonary rehabilitation. So the patient is able to walk more, the patient feels better, and how about hospitalization? This is the evidence comes from this and several other studies. This is a randomized controlled trial of 191 patients. These patients had exacerbation before within the last year, and patients who were randomized for pulmonary rehabilitation had less hospitalization over a follow-up of 1 year, 12 months, and it was statistically significant. They spent less hospital days, so they spent less time in the hospital. They were hospitalized less, the frequency is less, and the amount of time spent in the hospital is less. A very powerful study. The number needed to treat was 5.5 patients, so you need to enroll 5.5 patients in pulmonary rehab to prevent 1 admission. Okay, so that's what makes it really cost-effective. The same study shows that a more general reduction in healthcare utilization. We see that patients who were enrolled in pulmonary rehab had less ER visit for exacerbation, and the difference was statistically significant. They also had less number of unscheduled visits for family practitioners, so less utilization of healthcare resources. How about after exacerbation? So we get this patient that comes to the hospital. When is a good time to enroll the patient in the rehabilitation? Is it safe? So a few studies looked at that and found that if you actually enroll patient within a month after admission for exacerbation, the results are even more pronounced in everything that I mentioned before, and this is also a meta-analysis for readmission. And we have here 5 randomized controlled trial lumped in a meta-analysis, 250 patients, and we see a really sizable effect size in reduction in hospitalization in this patient. And we will see also that mortality is less, so it's not really it doesn't have a bad effect on patient who had recent exacerbation. So that's really what makes pulmonary rehabilitation cost effective. You save on the cost of admission. You're paying more for the rehab program, but you are saving in the long run for readmission, ER visits, and health care utilization. So in addition to this level A evidence, very convincing evidence, there's suggestive evidence, what's level B, that pulmonary rehab actually improves survival. Can you believe that? There's so many studies that looked at inhaled steroid, long-acting beta-agonist, everything is questionable, p-values of 0.51, and now we have suggestive evidence that we have an intervention that actually may improve survival in patients with COPD, in addition to oxygen replacement. So this is a meta-analysis here also from a Cochrane review that shows a sizable decrease in mortality in patients with COPD who undergo pulmonary rehabilitation after exacerbation. Now, why is that, despite the sizable effect, why is not level A? The issue is small sample size, so there may be a risk of bias. So that's why it's suggestive, not conclusive evidence. There's also suggestive evidence that pulmonary rehabilitation actually speeds recovery after hospitalization and exacerbation, enhances the effect of bronchodilators, so it's an additive effect on top of pharmacologic treatment, and that the benefit extend well beyond the period of training. So usually you would enroll the patient for 2-3 months, and the beneficial effect persists. So who would you enroll in these programs? It seems that all COPD patients appear to benefit. However, the benefit has been most primarily documented in patients with significant dyspnea, as measured by the MMRC questionnaire more than once. So anyone who cannot keep up with their peers on a flat surface, or who has to stop to take a breath that would put them in an MMRC grade 2, they would benefit. And after exacerbation, we saw that the benefit is substantial. So according to the new GOLD classification of group, it seems that patient in group C and D, so these are the patients at increased risk of exacerbation as measured by previous exacerbation history or severe spirometric impairment, has a beneficial effect from pulmonary rehab, as well as patients who are symptomatic, so patients with MMRC more than 1, 2 or more, B, so B, C, or D. And the weight of the evidence is so convincing that the most recent GOLD guidelines actually consider pulmonary rehabilitation as an essential intervention for patient group B and C and D, for these same groups. So they consider pulmonary rehabilitation as essential in addition to smoking cessation. Other indications beside what the guidelines say, specific patient that may benefit, the patient who have decreased functional status, decreased occupational performance, difficulty performing activity of daily living, psychological problems related to COPD, nutritional depletion, and increased use of medical resources may benefit. Now, who not to include? Who should be excluded from this program? It's basically anyone who has unstable cardiac disease. So a patient who has a recent MI, unstable angina, you don't want to have them exercise. Most patients actually will going to need cardiology clearance before they are enrolled. Patients with critical aortic stenosis, there's also dangers for them to exercise. Recent pulmonary embolism, you don't want them in your program. And there's also a category of patients who are so impaired that they're bed-bound. And these patients can exercise safely, but they're unlikely to benefit. So patients who are bed-bound because of severe dyspnea or musculoskeletal impairment are unlikely to benefit and should probably not be enrolled in these programs. Now, interestingly, active smoking is not a contraindication. Patients will still benefit, but these patients have a higher dropout rate. Now we'll move to discuss a bit the components of pulmonary rehabilitation. The most important and the cornerstone is actually the initial assessment, and it identifies unique problems of the patient including gait disturbance, nutritional depletion, and depression. So it's used to tailor intervention and bring in additional resources to the basic components. So we can get in psych consult, nutritional evaluation, or smoking cessation for patients who continue to smoke. The initial assessment is actually very detailed. It includes medical history, physical exam. There should be diagnostic tests. You should review the spirometry to make sure the patient fits the diagnosis. EKG should be done. And then a detailed assessment following specific questionnaires that review the patient's exact symptoms, the activity of daily living, nutrition, educational background, what they know already about the disease, and a psychological assessment. It's also very important to measure the exercise capacity at baseline and at the end of the test, of the pulmonary rehab program. So we use a 6-minute walk test or shuttle walk test to estimate the distance that they can move, and based on that distance, we can estimate their exercise capacity in watts, and we would tailor the intensity of the physical rehab intervention based on this exercise capacity. We can also do a CPAT, a formal cardiopulmonary exercise test, to actually measure VO2 max, the exercise capacity, and tailor the intensity of the program. All programs basically do one of those three and repeat it at the end to measure the improvement. And at the end, there should be a careful musculoskeletal assessment for exercise. Most of these patients are elderly. They may have osteoporosis. They may have difficulty ambulating. You have to make sure that it's safe for these patients to exercise. So you have to know their limitation and tailor some of the intervention to these patients. So some patients may not be able to climb stairs. Some patients may need to just do bikes and so forth. When this initial assessment ends, there's the goal formulation. So patient would sit with the coordinator of the program and they set their goal. The goals have to be measurable, they have to be patient-specific and realistic. And examples should be like the patient may want to be able to play with grandchildren or walk farther. They maybe just want to be able to take a shower without feeling suffocating, or able to clean their house, or even return to work. So all of these will have to be really set ahead of time. So like I said before, the exercise training is really the main component of pulmonary rehabilitation together with education, so we'll talk a bit about it. The exercise training not only helps the patient cope with the sensation of breathlessness. It was thought initially that all we're doing is we just teach the patient to accept their dyspnea by just getting used to it. Actually, there have been studies that looked at peak oxygen consumption, peak workload, endurance time, and they're all improved in patients who undergo physical exercise training, which suggests that it actually improve muscle function and cardiopulmonary function. It's not just getting used to the idea of feeling dyspneic and keep going. The recommended number of exercise session is 20. At least, and the frequency, the recommended is 3 times per week. It's okay to do 2 + 1 at home. That's what we actually adopted in our program at AUB because of transportation problems, and really it's impractical for patients to come 3 times to the program. The length of program, the recommended is 6 to 12, although the longer program have shown to confer more prolonged and added benefit. The session duration is anywhere between 20 to 45 minutes, and the intensity of exercise, I remember I told you we measured the VO2 max, or we tried to estimate it based on the 6-minute walk test initially, and then we would dial in and give an exercise prescription of 50 to 100% of the VO2 max. Usually high intensity is preferred, but patients who cannot tolerate that would still benefit with low exercise intensity. The modes of exercise, initially there was a focus on only endurance training, but then the evidence showed that adding strength training, so weightlifting and elastic bands, TheraBands, would actually confer additional benefit. And the exercising both lower and upper extremity are beneficial. So we basically do a combination of both upper exercise, lower exercise, endurance, and strength training every time the patient comes. 2 words about respiratory muscle training. Although it's appealing, you would think that the diaphragm suffers in patients with COPD and you want to train it. It's not really recommended. It's not been shown to add benefit on top of endurance and skeletal muscle training. Although it's been shown to increase muscle strength and endurance for the diaphragm and respiratory muscle, the effect on exercise tolerance and quality of life is not proven, so it's okay to include it, but it's not really recommended. Oxygen therapy during physical rehabilitation is of paramount importance. It's very important to measure their oxygenation during exercise. Measuring the oxygenation at rest will not predict what's going to happen during exercise. And so it's very important to maintain an oxygen saturation above 89% and to supplement with oxygen to improve exercise tolerance. Bronchodilators also very important. As we said, it's an add-on effect to the bronchodilators, so it's very important to optimize home therapy before the patients are enrolled, and it's very important to have bronchodilator available on premises to give if the patient develops wheezing or even prior to initiation of exercise. It's very also important to have a crash card in the rehab program in case problems arise. So very important to have oxygen, nebulizer, and ability to perform ACLS if the patient is in trouble. I'm just going to mention 2 words about the educational component. It's going to be covered more details in a later talk, but it's also an essential component of pulmonary rehabilitation. The sessions are to be coupled with exercise training. So the patient comes, they go through an educational session, then an exercise training session. And the education component is not really just a didactic. The patient don't sit there and listen to a talk, although some information is important because it improves their communication with their care provider. It's the main education component is skill-oriented and also focus on self-monitoring and give the patient an action plan. This will be talked about in more details in a subsequent talk. I'm going to skip through those as they're going to be covered. And I'm just going to end by saying and reiterating an ATS statement on the integrated care of COPD patients, that focusing therapy solely on reversing airway obstruction is now considered suboptimal care and will produce suboptimal outcome. I thank you for your attention.
Thank you, Dr. Chami. We are a bit pressed for time. I will open the grounds for 1 or 2 short questions. Any questions? Yes, please.
Yes, go ahead.
Thank you very much. شكرا جزيلا على هذه المحاضرة القيمة. معلش أتكلم بالعربي؟
تفضل.
نحن عرب ونتكلم بلغتنا العربية.
ما بيصير.
الواقع أنا بدي أتكلم عن الأردن. بالأردن في عندنا 5 ملايين بشر. هال5 ملايين 2.5 مليون بدخنوا. 2.5 مليون في عندك 250,000 is going to have COPD.
Yes.
معناتها بدك ميزانية الشرق الأوسط كلها لتعالجهم على الجولز تبعك. نيوتريشن واكسرسايز و6 minutes walking وECG PFT. فليش ما نكون واقعيين جدا جدا ونعمل حملة شرسة جدا على التدخين وبالتالي ننقذ الأمة العربية من هالوباء القاتل.
أنا
ملاحظة
موافق معك 100%. بس في ناس اوريدي عندهم المرض مش رح تتركهم.
هيدي نحن بنشتغل عليهم اصلا. نحن كيف بدنا نعيش اذا ما في COPD؟
بس I'll give you what to do.
لا خليهم موجودين الله يرضى عليك ويدخنوا وبالليل يأرجلوا مش اشكال يعني. بالنهار يدخنوا بالليل يأرجلوا. فانا بدنا شغلات براكتيكال الله يخليك. هلا شغلات نتحملها مو شغلات نتخيلها. يعني بدنا شيء واقعي لهال4 مليون في الأردن اللي عم بيدخنوا واللي معهم COPD واللي أكلين هواء فاينانشالي وسوشيالي وميديكالي واتسترا. شكرا جزيلا.
أنا بدي أتشك حسن معلش بس تعقيبا على اللي قاله الحكيم. إذا فهمت مظبوط if I got it right ال pulmonary rehabilitation especially if it's tailored إذا معمولة على قياس المريض المنفعة تبعيتها أكبر من معظم الفارماكولوجي اللي نحن عم نعطيها واللي عم بتكلفنا بلوي. فأنا بتصور إنه الحملة اللي بدك تعملها للدخان واللي هي تكون مشكورة بينعمل معها حملة بنفس القوة للpulmonary rehabilitation لأنه برأيي المنفعة بتكون للميلتين المريض اللي already صار عنده المرض واللي فينا نمنعه يصير عنده المرض. هون بس أنا بدي يمكن اسمح لحالي بسؤال بسيط هذا يمكن حيبين بعد شوي بالlectures بس is it covered? Insurances, do they cover this service? And if not, how much does it cost?
The hopeful answer is not yet.
So not yet.
We're actually working with insurance companies to convince them of how cost-effective this intervention is in order for them to cover it. And it's still up in the air. We haven't heard back from them. So that's one limitation. But I totally agree. رح ارجع احكي بالعربي. الكنديان هن عاملين اكثر شيء ستاديز على البولمونري ريهاب. 3/4 هدول الميتا اناليسيس كلهم من كندا. They actually compared hospital-based outpatient, يلي this is the gold standard هلا, to home care. So you don't actually have to enroll patient in an outpatient hospital-based setting. What you can do is have an expert and specialist give them an exercise prescription and follow up on them while they're at home, okay? And even walking, you don't have to go very sophisticated, and you will have some benefit. But it's still important to have a center of excellence where you would have a formal pulmonary rehabilitation program so that you get the expertise for those who can afford it, and then build also a community-based and home-based that's less expensive. So تعمل البروجرام المضبوط حتى يصير في الاكسبرتس وبتعلم الناس بيعملوه ببيتهم والكوميونيتيز. هيدا الكندي اللي عم بيعملوه and it's been shown head to head انه home based is at least as good to hospital based outpatient.
Thank you very much. I guess we have to move. We're already behind schedule. بدنا ناخده من وقت عقيقي بعد شوي تحكي عن ال EUV program. I will introduce Dr. Rami Abbas. Dr. Abbas is an assistant professor of physical therapy from the Faculty of Health Sciences at Beirut Arab University, and he is the head of the physical therapy department at Maqasid General Hospital. Dr. Abbas will talk to us about let me see the
mucus clearance,
the exercise training in COPD, the new perspectives. Dr. Abbas.
Thank you. I would like to thank the organizing committee of the conference. My lecture is how we can clear mucus in physical therapy. مشان دكتور بس كمان رخيصة هذه ما بتكلف. Content of the lecture عنا basics of normal physiology mucus clearance from physical therapy point of view, air and fluid dynamics, and how physical therapy help to manage mucus clearance. As normal physiology, what's mucus? Mucus is composed of 95% water, 3% protein, carbohydrate, lipids, DNA. The bonds are the objective of medication to break up the bond, to let the mucus be more easily to be get it out from the body. Normal production per 24 hours per day is it's reabsorbed back in the bronchial mucosa. 10 milliliter reach the glottis. Most of this is swallowed. Mucus production increases with lung disease. Of course, I don't want to speak a lot. Smoking, environmental, allergy, infection, genetic predisposition, and foreign bodies. Increased mucus production produces the increase in viscosity of mucus, decrease in ciliary effectiveness, mucus plugs, airway resistance, and infections. Disease that increase mucus clearance production, we have lots of diseases, and you all know them. I will start with the airway histology. From the histological point of view, we can notice that the mucociliary escalator that helps the clearance of secretions is mainly present in large conducting airways and small conducting airways. But in the alveoli, we don't have cilia. The mucus layer, usually the gel is 1 to 2 micrometer. The sol is 4 to 8 micrometer. Surface epithelial cells, we have many cells. Submucosal gland, bronchial gland that are found in submucosa, found down in the terminal bronchiole, are innervated by sympathetic control, vagus nerve, and provide the majority of mucus secretions. The total volume is 40 times greater than the goblet cells. The mucociliary escalator is like a blanket. The cilia are well equipped to move the mucus 2 centimeters per minute. The protective function of the cilia, I know it's an introductory, but I'm needing it to explain our point of view. Its protective function is to remove trapped and inhaled particles, antimicrobial, humidification, and insulation. Mucus also protects the epithelial cells from toxic materials. This is the action of the cilia that we can see from both sides, from the top and from the lateral view. That takes around 7 milliseconds to do the whole range of it. Mucociliary escalator is only applicable in conducting airways containing cilia, and it's not present in the alveoli. So how can we, as physical therapists, drain mucus or secretions from the alveoli? And second, our approach is not to make the cilia work more or less. Another thing in the histology is the presence of the cone spore that I will explain later, why we can use these spores in pulmonary rehabilitation. The main factors affecting mucus displacement thus are the viscosity of the mucus, which is not our topic, inhaled and expired air dynamics, this is where we work, and ciliary motion, I think we don't have any work to do in ciliary motion. So we as physical therapists in mucus clearance, we mainly focus on inhaled and expired air, and we are based on physiological and physical basics that are aerodynamics. Air fluid dynamics, airflow through tubes. As airflow through a tube, a pressure difference exists between the ends of the tube. This pressure difference depends on the rate and the pattern of airflow. This is what we are going to manage. Airflow at low flow rates is usually laminar, and I will explain what's laminar. And turbulent airflow will be at higher flow rates. What's laminar? Laminar flow is parallel streams of flow. Velocity at the center is twice as fast as the edge of the tube, and there is a physical law, Poiseuille law, that describes the resistance to a flow through a tube. Pressure increases proportional to the flow rate and gas viscosity, and the smaller the airway radius, the longer distance increase the flow resistance. This is the formula I want to see. The formula I just want to see that reducing R by 16% will double the resistance of the airway, and reducing R, the radius, by 50% will increase resistance by 16-fold. This is what we call the Poiseuille flow, the laminar flow. That is mainly, it's double at the center and it's half at the periphery. This is the laminar flow that occurs at low flow rate. Turbulent flow occurs at higher flow rate, and it causes local eddy currents that are like this, that will go on to break up the secretions if the flow is at high lung volume or a high flow rate. Another physical fact is that there is the Bernoulli's effect, that when we do an expiration in a physiological or in airways, in the human airways, we will have a compression or a collapse dependent on the presence of the flow of the air that's going out from the alveoli. And if we consider here, this is the alveoli, and we do an expiration, there will be, at a certain place, there will be a compression or a collapse in the airways. So how can we use what we just said to manage mucus? We can increase air entry to alveoli. This is what we call the interdependence, that the mechanism whereby air may be moved into small airways obstructed by secretion by increasing tidal volume. So what we do is that we ask the patient to inspire, to hold a little bit the breath. So we will use the cone spore to do what's called interdependence. During inspiration, expanding alveoli exert a force on adjacent alveoli described as interdependence, and it may assist in the re-expansion of collapsed alveoli. This is because we don't have cilia. The effects of interdependence are believed to be more marked during deep breathing. What I meant is here and on the right, we have here collapsed alveoli, and this is a normal diffused alveoli. So the interdependence between the cone spore will help the air to enter the closed alveoli. The halving mechanism that we use as physical therapists, when airflow over a thick mucus layer, shear forces develop on the surface of the liquid layer. This is what we call the shear force that we are using by the expired air to help the mucus to move from a place to another. And we have lots of patients with COPD that don't have good working cilia, and the ciliary escalator is not working good. So we can use the expired air to push on the mucus plug. It's proportional to the square of the airflow velocity. When a shear force exceeds surface tension in mucus layer, there will be mucus will begin to move in the direction of the airflow, and finally the mucus flow is greater when expiratory airflow velocity is increased by at least 10% compared to inspiratory velocity. This is what I meant by the Bernoulli's effect. If we do the expiration at very low lung volume, the narrowing or the bronchoconstriction will be done at the level that is very close to the alveoli. If we do it at a higher lung volume, the effect will be on more distal or more peripheral airways. The forced expiratory technique, HAF, is a combination of one or more or two or more forced expiration huffs and periods of breathing control. Huffing to low lung volumes should assist in loosening and mobilizing excess bronchial secretions from smaller peripheral airways to larger central airways. And when secretions reach the larger upper airways, a huff or cough can be done with high lung volume to clear them. There are, of course, I will speak about evidence later on. Forced expiratory maneuver are probably the most effective part of chest physiotherapy for mucus clearance. The coughing mechanism is achieved by rapid airflow acceleration and extremely high flow rate. When coupled with dynamic airway compression, is very effective in squeezing and clearing mucus from airways. Cough can be directed in trained patients. As cough mechanics, the inspiration is generally deeper, about 1.5 times of the tidal volume, increasing elastic recoil. High intrapulmonary pressures are built up behind the glottis. When the glottis open, supramaximal turbulent expiratory flow are generated. During cough, the posterior membranous portion of the trachea is compressed and tracheal diameter is narrowed at about 1/6 of the normal. With an increase in flow rate of 7-fold during the cough, the linear velocity increases to 42 folds. This is what makes the turbulence and will help us to clear the mucus. Airflow at the site of compression is turbulent and make the sound that we call cough. Active cycler breathing, another method we use, it's divided into 3 parts. First, the breathing controlled normal tidal breath, thoracic expansion exercise to deep inspiratory breath with the hold to have the interdependence in the conspore, and finally the forced expiratory technique, 1 or 2 huffs from low to high lung volume, and that can be repeated in order to mobilize and clear bronchial secretions. Why the hold? I repeat here because we want the air to enter the closed or blocked alveoli and to help, and the expired air will help in the mucus clearance. Autogenic drainage is another technique that we use. It's divided into phase 1 to unstick in the expiratory reserve, to unstick, then to collect with higher lung volume, and finally evacuate with more high and more rapid airway flow. Does this, what we are saying, is theoretical or is it evidence? Evidence is, Dr. Chami has spoken good about evidence in pulmonary rehabilitation, but here I'm taking just a part that is the mucus clearance. Many recommended guidelines, I've chosen one. Pursed lip breathing has been found to be quality of B and C. It needs more research. Slow and deep breathing, C. The active expiration, B and C. Coughing and huffing and autogenic drainage are A and B, A2 and B. And positive expiratory pressure, A2 and B. I just want to thank you for the listening.
Thank you very much, Professor. And thank you for finishing a bit early because you were pressed for time.
Yes.
I will start with a simple question.
Yes.
Do you think that the chest physiotherapy that we do on our patients that have secretions, do you think there is a certain way of doing it that can give us more benefit? And what does the patient have to do meanwhile?
according to my experience in the hospital, physical therapy, chest physical therapy is essential, and it prevents lots of complications. There is a problem with the third-party payers, of course, but if we took this part apart, if we take it apart, without speaking about financial and management problems, it's very effective because all physicians that tried what's the benefit of post-operative physical therapy or bedridden physical therapy patient for physical therapy bedridden?
I was talking about respiratory therapy when we do the clapping and things like that.
No, the clap. As you say, I didn't spoke about clapping because clapping it's it's nothing. Because it's clapping,
so essentially, it does not confer any significant benefit.
No. Essentially, you must manage the expiratory flow. So if you use the expiratory flow, you will help the secretions to be excreted with 10 to 15 minutes.
Training the patients to breathe properly and use maneuvers properly is more effective and better than the clapping that we do.
It's nothing. For COPD, we teach them at many instances because there are sometimes small tricks that the patient will learn by time. And if it's a chronic case, it's easy. The problem is the acute cases. Post-operative, this is you have to teach him. It's not a patient, chest patient, and you are preventing. You are getting out the secretion to prevent a complication. But if you have a chronic patient, he will learn the maneuver and he will do them, and he can be followed up every 3 to 6 months. And the maneuver are very easy but tricky. You have to choose. It's like the problem with the inhaler that chest physician have, and how to use the inhaler.
So once they get it right, it's very effective.
Exactly, it's very efficient, and you get the secretions excreted now, not late. Within 1 hour maximum.
Excellent. Any other questions? Yes, we'll take one of the two. Who was first? Because we're really pressed for time. Ala rasi. Yes, go ahead.
Yes, I want to say, ask you if mucohumidificators are useful for
humidificator?
No, mucolytics.
Mucolytics are
aerosol therapy.
Yes, mucolytics. The way of action is on the bonds of the mucus that I explained in the first slide. And in the beginning of the slides, I said, mucus is composed of, it has bonds. The bonds are responsible for the viscosity. So all the medication, which is not my specialty, are working to break the bonds, to make the mucus more viscous, and to be excreted, and to make the job easy for the cilia to take it out. But it's not our job. What we do, and we can use a humidifier, humidify the inspired air to help the secretions be more humid, more less viscous, so that they can get out. But as a physical therapist, it's not my part.
Very quick, Hakim, Allah يخليك.
السؤال
نحن رخاصها ما بنكلف كثير
جدا. السؤال السريع كثير انه هو سالك سؤال قريب للي انا بدي اسالك عليه، انه giving hypertonic solutions على اساس to increase
excretion of secretions.
بقول لك بصراحه نحن انا اشتغلت بمستشفى وكله كله بيصير with physical therapy for mucus clearance مع كل الاشياء الثانيه، واكيد الافكتيف اكيد افكتيف. ما قال لك I didn't do a research concerning، بس انه كان نحن شو البارت تبعنا كفيزيكال ثيرابي، نحن بنستعمل الهواء بس، دخلت الهواء وطلعت الهواء.
So the maneuvers essentially.
بس exactly.
طب مشان الاطفال والسيدات،
مشان الاطفال اكثر ما بتتصور الافكت. اذا بدك انا رايي as a pediatric with premature, and I had hopeless cases of atelectasis that has been treated for 1.5 days. طلع من الانتنسيف كير بيوم ونص بس
كيف طلع؟
لانه يو ار انت بالاتلكتاسيس بدك مشكلتك انه بدك تعمل بوزيتيف انتري للاير. مجرد ما خليت الهواء يدخل على الالفيولاي وعملت مانجينج بتطليع الهواء مش الحق.
Thank you, Dr. Abbas. I really have to get going. It is my pleasure to introduce Mrs. Alina Ai'i, with an apology for taking part of her time. Mrs. Ai is the program coordinator for pulmonary rehabilitation at the AUBMC and works closely with Dr. Chami, and she has master's degrees in several disciplines in nursing and is an ICU nurse by trade. Mrs. Ai, please.
Thank you for your invitation. Thank you for coming. Today I will be talking about educational component of the pulmonary rehab. And I will be talking about the recommended education process in pulmonary rehab. What are the evidence? Is there any evidence, any literature review? What are the components of the education program? And about the strategy that we can use to enhance patient self-efficacy. By looking at the component of the pulmonary rehab, we can see that education is an important component in the pulmonary rehabilitation. And studies have shown that traditional education, didactic education, is insufficient to promote behavioral change. What we need to have is to have the patient adopt a new behavior. It's not only increasing his knowledge. We want him having some behavioral change on optimizing disease control. For that reason, the didactic information is not anymore used. And the American Association of Cardiovascular and Pulmonary Rehabilitation recommend in their guideline using collaborative self-management education. What we mean by collaborative self-management education? It is a program, formalized patient education, where we teach patient skills. We don't want only to teach patient knowledge. We don't want only that the patient side that COPD has this and this and this symptoms. We need at the end of the program that the patient use such pursed lip breathing to clear his secretion. We want him to know how to monitor those symptoms. We want him when to report those symptoms, how to adapt body position to decrease dyspnea. Also, the collaborative self-management help patient guiding health behavioral change. We expect that the program and the education target that the patient will be helped to change his behavior. We want the patient, for example, quit smoking, increase physical therapy. And we want to provide him emotional support to control their disease. Mainly, usually, self-management education address patient knowledge and the skills, increase their skills, work in self-efficacy, work on behavioral modification in order to have health impacts such as prevention of complication and prevention of emergency visit. What we do in self-management education is help patients monitor and manage the signs and symptoms, engage in health and lifestyle behavior, teach him how to take properly the medication, and maintain a regular contact with healthcare provider. Is there an evidence, and what's the evidence say, what the literature say? In a Cochrane review done, it shows that self-management education, people who receive self-management education have an improvement in health-related quality of life. There is a statistical significant improvement related to health-related quality of life as measured by St. George Respiratory Questionnaire. The same Cochrane review also showed that there is a statistically significant improvement, decrease in the respiratory-related hospital admission. The number to treat vary between 10 to 24. Actually, we need to educate 10 people who are at risk of 51% risk of exacerbation to have one decrease in hospital-related admission. And we need to educate 24 to have a decrease in one hospital-related admission for patients who are at 13% risk of exacerbation. Cochrane review showed that self-management has no significant effect of the number of the exacerbation, emergency department visit, exercise capacity, and delay lost from work. When we should give the education? As per perspective, taking perspective from the patient would like to have education session held first. People, they see themselves tired having education after the exercise, so it's better to have them before the exercise. And what are the topics that we'd like to discuss in the pulmonary rehab? Usually, we need to teach patients about how to early detect their exacerbation. And it is an important topic since earlier treatment is associated with faster recovery, and failure to report exacerbation is associated with an increased risk of hospitalization with a significant p-value. in order to help patient early detect exacerbation, we need to supplement him with an action plan. This is a kind of action plan where the patient is helped how to classify himself in a zone. Green zone is the patient is of exacerbation. Those are the symptoms where the patient can check on himself. And if the patient is in green zone, the patient has to take his usual medication and to be on oxygen therapy if it was already prescribed by his physician. And in case the patient in a yellow zone, this is patient where he's in exacerbation, patient he has to call his healthcare provider in order to take his antibiotics and to be on corticosteroid. If the patient is in red zone, patient need to come immediately to the emergency unit. So during the program, patient need to be taught how they can evaluate themselves and classify themselves as per zone. To bypass language barriers, we can use pictorial educational action plan. It's easy. For example, if it's sunny day, just take your medication. If there is signs of cough, change in the secretion, you have to call your healthcare provider. And if the signs persist, you have to go to the emergency unit. Teaching patients about how they can prevent their exacerbation is an important topic. And during the session, we expect that the patient have a way to remind themselves about their vaccination, when they should take their vaccination, the benefit of the vaccination, and it should be associated with a discussion about the correction of misconception about vaccination. Sometimes people don't like to get vaccinated, so we'd like to discuss with them about those misconceptions. A basic COPD education about anatomy, physiology, what's COPD, medical test, a basic understanding is important. This increases the patient's ability to comply with their treatment plan. Although it is the physician who prescribes medication, but it is the role of the pulmonary rehabilitation educator to make the patient know about the indication of the medication, how they work, and we expect them at the end of the session that the patient will be able to differentiate between long-acting medication, short-acting medication, corticosteroid medication, and medication that are to be used during exacerbation. Inhaler technique has been problematic for every patient using inhalers, and there is a study that have been shown that there is an increase in dry powder inhaler handling error associated with the severity of COPD. The more the COPD is severe, the more we have percentage of error. Pulmonary rehab educator is responsible about educating patient how to use the inhaler, how to recognize the inhaler is empty, how to prime his inhaler. Usually patients are asked to bring their inhaler with them and to do a demonstration and re-demonstration to make sure that the technique is very efficient. At the end of the session, patient is provided with a pamphlet. It's an educational pamphlet. It is a good resource for the patient to use it after leaving the program. This is an example developed by an American College of Chest Physicians and Chest Foundation. We need to help patients increase their physical activity by discussing with them the benefit of exercise, how to prepare themselves to exercise, and how to monitor themselves. We mean by that how they use Borg scale to monitor themselves, how to take their heart rate in order to keep in a safe way their exercise. To make the exercise to make them adopt and enhance adherence, we want to help them having a home exercise program. And a home exercise program is started from the beginning, from joining the rehabilitation program. It includes breathing technique, floor exercise, strengthening, biking, and walking exercise. Patients need to be taught about how they can manage their symptoms. We need by that using breathing strategy, using how they can use pursed lip technique, how they can adapt position, and how they can clear their secretion. Moreover, we want to help patients by giving them education about how to maintain a daily living activity by using energy conservation and work simplification tasks. And we need to help them resume and maintain their leisure activity by helping them plan. Usually patients who have COPD, if they are on oxygen therapy, they consider they cannot go for a plan. So we want to help them resume this activity, and we need to help them resume sexual activity by having discussing this problem and prescribing the body position that suits their dyspnea level. Every patient coming to the rehab should be assessed for his willing to quit smoking and should be encouraged for willing to quit smoking. Patient in the rehabilitation program is helped with behavioral strategy and is offered nicotine replacement therapy. A psychologist specialist helped the patient to cope with the stress by teaching him relaxation technique and stress management technique. And also a dietitian will help the patient to know how to eat in the right way. Usually patient can be depleted or can be overweight. So as patient assessment, proper education is given. Moreover, education concerning what type of diet he has to follow during corticotherapy is discussed. And having those topics discussed with the patient doesn't mean that the patient immediately will go and adopt the technique learned or the skills learned. We need to help him increase his self-efficacy. What we mean by self-efficacy? Self-efficacy is the belief that one can successfully execute a behavior. They need to have this trust in themselves. I can do this. And to help the patient know that I can do this, I can perform this action, we need to help them. We need to use some strategy. One of them is practicing. The more the patient practice, the more the patient feels that he can do. So for that reason, in rehabilitation program, we need to help patient practice the skill first. We need to see the patient using pursed lip technique. You need to help the patient seeing him training. So, and the patient would like to have feedback and would like to have reinforcement. Usually patients are happy to have feedback, and the feedback could be a biofeedback, like increase a six-minute walk test, or reinforcement and talking with them. Each visit is a time where we should have feedback and patient reinforcement. Vicarious experience is another technique. Vicarious experience gotten from people who successfully completed the program. Usually people would like to share their experience, and they would like to learn from peers who had successfully achieved a change in behavior. Also, we want to help patients make behavioral modification. A behavioral is most likely to reoccur if the person actually experiences positive effect. So usually in the pulmonary rehab, we want the patient experience this positive effect. We set for him a goal, and we gradually increase the goal in order to have a behavioral change. We hope that patient education will provide patients with the required skills and will enhance self-efficacy in order to promote decrease in patient admission, related admission. Thank you.
Thank you very much for this concise review. It's quite impressive. We are already over the time allotted. I want to thank everyone for attending this session on pulmonary rehabilitation, and I close the session. Thank you very much.